Hi guys, welcome back to Inside the GC. I hope everyone is doing well. I'm actually riding solo host today, which is kind of scary yet really nerve-wracking, but also really exciting. Jake's actually out and about and away, so yeah, it's just me today, which is exciting. I'm not actually fully solo. We've got our first ever guest on our podcast, which is so exciting. We can have a little applause. Woo! This is Fatima. Welcome, Fatima, to the podcast.
Hello.
How are you today?
Hi, Charlotte. I'm great. I'm excited to be here and happy to be with you on your first solo podcast.
I know. First of all, I'm solo, but second of all, this was a podcast, Fatima's first ever podcast as well. Yes. So we're kind of riding the same boat here, which I'm actually quite like, this has eased my nerves just a little bit.
Likewise.
I'm really hoping that this one goes really well for you guys. We've got so much to chat about: women's health, Ozempic, about Fatima and her journey into fitness, all of that good stuff. So yeah, let's get straight into it. Okay, so Fatima, hello.
Hi.
Tell us a little bit about yourself and how you got to where you are today.
Oh, wow. How long do we have?
We've got all the day if you want to.
All right. Well, okay.
Short and sweet.
So I'll just give you the brief version. I'm Fatima. I am a doctor by profession, but I am also, I would say I'm a general practitioner on the NHS, but I'm also a lifestyle medicine physician. That's sort of where my passion is. Mm-hmm. And I would say my journey started becoming a doctor. I always known I would be a doctor because from the age of 5, my mom kept saying, "You're going to be a doctor." And that was it.
I love that.
From the age of 5. And I had 3 brothers and I grew up with 2 of them because they were born close apart. And 2 brothers, always fighting, always having injuries. And me being the doctor, I remember as a young child, always, with their bruises going with like antiseptic and cleaning it up and putting a plaster on it. So I always knew that.
Oh, did you have one of those little like doctor kits?
I had it all. I had.
I love that.
I had the fake stuff, and then I have 2 uncles that are doctors, and they used to give me like old stethoscopes. I actually had the real stuff as well. So it was just something. There wasn't anything else I was going to be. Yeah. And I went through the journey. 6 years of medical school. 2 years of training after medical school, and then into the specialty training as well. Mm-hmm. That's general practice specialty training, which in the UK is about 3 years.
Oh my gosh, this is already 9 years.
Yeah, 9 years plus. No, actually 11 years at this point, because you do the 6 years and the 2 years, and in between you work an extra 2 years, then you do the training. So we're looking at really 15 years of
15
of actual
years.
Yeah, of actual.
I was like crying that I had to do 4 years at university. 15 years.
Yes.
Gosh.
At least 15 years. I'm not trying to discourage anyone from being a doctor. It's an amazing profession.
Incredible.
I would say though that one thing about medicine is that if you're going to come into it for the money, it's not worth it. Don't do it, because you have to come with passion, because without passion, it's, you're doing it for the wrong reasons.
Yeah. That's so true.
And I think that's one of the things that also made me decide to go into a field of medicine that's not fully utilized, especially in this environment, the lifestyle medicine side of things. Yeah. Because obviously after all the training and everything else, I'm now working in my, NHS clinics. Yeah. Sit down and I have I call it like a conveyor belt of patients coming to me. Yeah. And over the years, you kind of see a pattern of like people just coming over and over for things that could be better prevented or managed with lifestyle measures. And all we keep doing is, okay, you need to go do this. We tell them do this, but we don't exactly tell them how. Yeah. But because we don't have the luxury of time and sometimes even the resources, we kind of, do what I call Band-Aid fixes or firefighting. We just, give a little pill and say, come back in 6 months or 8 months or whatever. But it's just that constant.
And just a quick note one on that, because that's quite intrigued me. Would you say some of these lifestyle measures that you need to advise these people are just general ones about fixing diet and exercising. Is that what you struggle with, to tell people how to do that? Or is it more like, oh no, like they've actually got some more health related diseases that they need to go and fix with X, Y, and Z?
Bit of both, because most of the diseases that we end up seeing or treating as a result of, I guess, poor lifestyle choices. Yeah. Although some of the lifestyle choices, there are certain aspects that are within their control and lots that are not within their control, you know, which we can elaborate on in a minute.
Yeah, of course.
But then the part of explaining or educating them on how to do it, that's where we have a problem. Because even in medical school, you know, we do get education on, the importance of, you know, diet and exercise, but we don't really get a lot on how to kind of present it to our patients, because it's kind of like, tell them to exercise. Okay, what is exercise? Okay, is it just sitting down? Is it walking 20 minutes, or is it, you know, running 20 minutes? Is it lifting weight? We don't get to you know, we don't get to learn a lot about that. And it's probably later on in our in our jobs that we kind of on our own you know, try and educate ourselves to educate our patients. But then you don't, when it comes to talking about lifestyle, 10 minutes or 12 minutes is not enough. You know, you just can't tell a patient that in 10 minutes and they go and do it, and then you expect that would be that. It has to be like a constant reminder, repetition.
I guess it's guidance. Like us in the gym and what we do as our, what we do with our members there. And obviously you're a member of, I didn't already say, Fatima is a member at the GC. She is pro GC. And it's what we say to our members. We're in the constant repetition of, you know, certain ones we have to constantly say, like, remember it's protein, remember it's calorie deficit, remember it's lifting weights over this and And I think, you know, even we ourselves don't always get like an abundance of time with these people to be like, okay, this is what you have to do. You know, we're the same with our sessions, one in, like kind of one group in, one group out type of thing. So yeah, I totally get that. And that's where, like you say, the NHS does struggle with it, is the kind of time concise you have. Like you only have like you say 10, 15 minutes to chat to a patient about their specific issues. Which, like you say, we'll definitely elaborate on. So that's really, really great. And obviously, like you say, you don't just specialize in your like general practice. You also are an holistic and lifestyle doctor, which again, we'll get into a bit more. But as I was mentioning to you before, like you've been with us for a while now. How long have you actually been with us? Is it like over 2 years?
I think it's over 2 years. Yeah, over 2 years.
Because I've nearly been here 2 years. So and obviously I was here when you joined. Well, when
I was there when you joined.
So it's very clear that like your values align with ours. Like we obviously want to support people, making them feel stronger, fitter, healthier, all through nutrition and lifestyle choices. And you've shown like really great trust in us to guide you on your journey as well. So could you just share a bit about your experience at the GC and how we've supported you in your journey? Yeah.
So personally, I would say this now, that I've struggled with, you know, I would say weight and physical activity, or getting it right most of my life. You know, I've always tried, you know, a different type of gym or a different type of exercise class or different types of diets, you know, throughout my life. But I think over time, once I understood that, look, I cannot just expect I didn't want to focus on just the result of losing the weight and that was that. So I had to change my mindset to say, look, this has to be something about keeping healthy, not just for the short term, but for the long term. And the only way to get that is with consistency. And I think that's where GC comes into place, that consistency, because that's one of the ethos there. You know, you have to be consistent. You have to show up. You have to, you know, keep coming to do it, put it in the work. It's not just that, it's not that focus on, you know, if you did this exercise in 6 weeks, you're going to lose this, or you're going to gain X percentage of muscle. It's about that continuity. And at this point, when it comes to physical activity, for me, it's actually not about the physical part, is now the mental part of it. So it's because as you know, I come in for classes at different times, sometimes late.
Half an hour late. I'm joking, guys. She's actually so great, but it's so funny. She comes running through the door.
I come running through the door because...
like 6:40.
Yeah, because sometimes I come in immediately after my clinic because I need those sessions to, as sort of
just
like
de-stress.
as a de-stress.
Yeah.
You know, it's physical activity, it's hard, but that, you know, that mental side of things, you know, I suppose the endorphins that come afterwards help, but it's now more about that
being able to switch.
That switch for me is why I'm consistent, and I know that you can never go wrong with physical activity. You can never. I can never go wrong with improving my heart health, my brain health, my my gut health with physical activity. So you know, it's like it's the best all rounder pill for me. So
I love that,
and that's just why I feel, you know, the GC is a place that I can get that. And of course, you know, seeing you guys there is a bonus. So,
Thank you. Well, no, that's really great. And I think you said something just at the end there, like pretty much like nailed it on the head with like, that's the pill, like that's the medicine. Like Jake and I always speak about movement is medicine and food is medicine. And there's so many ways that we can prevent like health related diseases through our exercise and through the what we eat. And that's what I did when I did my master's. So obviously I did sports science. And then when I went on to my master's, I did nutritional science, which delved into so much more deeper things when it came to food and our bodies, and then like metabolic syndrome, health related diseases, etc. And I think that's what's so great about you as a doctor who's advocating for movement and advocating for the right foods. And you're all about balance yourself. You know what I mean? We're all about balance here. We're not going to say our diets are 100% clean or anything like that. Absolutely not. Like, you know, we sit and chat and have nutrition talks like quite a bit. So I think it's just great how you can then show that to the people that you hopefully see and on an everyday basis as well. So yeah, that's so good. So obviously, as you say, you're a full-time doctor, you work within the NHS and you've also got a private practice open as well. Could you just kind of delve a little bit more into that as well and tell us about how that's a little bit different from the NHS and what you kind of deliver on there as well, if that's okay.
Well, so yes, I do run my own private lifestyle medicine clinic. It's called Alkali Health.
Yeah, we can link it. I can link it on Spotify.
So that's Alkali Health Lifestyle and Weight Loss Clinic. It's an online service predominantly. And I think one of the drivers for me to start the clinic was just because I needed to know that I could have time with my patients. I already mentioned the limitations with the NHS, time and resources we don't have. But one of the things about private practice is that it allows the patients, or should I say the clients, to have more time with their doctors, to talk to them, to let them know about, you know, where their struggles are, you know, why things are the way they are for them. And to be fair, like one of the, if we had a similar thing in the NHS, we wouldn't be having some of the problems that we have. It's unfortunate that, you know, the system doesn't kind of understand that needs to happen. But then again, I understand not enough resources, but then to get enough resources, you need to put more funding into things and so on. But so what my clinic focuses on, it's kind of giving that time so that we can explore the reasons why, you know, individuals struggle with, you know, health issues or are at risk of certain health issues, because it's not just about, a lot of things are things that are not within their control. And when sometimes having the understanding that these things are not within your control, this little bit is within your control and this is what you can do for it. It almost like serves as this motivator for people. You're like, okay, well, I know I can't deal with it. I'm not going to bother about, say, for example, you know, like your genetic risks. Okay. Genetics are not your destiny. I agree. But sometimes there's certain genetic risks that once they're switched on, you can't change it. But if you know that, you know, adjusting certain things in your lifestyle, which is predominantly your nutrition, physical activity, your social interactions, you know, use of substances. So for example,
let's say someone genetically, their parents had type 2 diabetes. So both of their parents had type 2 diabetes. They're then at a high chance of
very
getting
high, 25%.
25%. There's some statistics for you there. guys, listen up. So 25%, obviously, and they're, let's say their parents are type 2 diabetic because, I don't know, it was their lifestyle choices, okay?
Yeah.
So they had poor diet, they didn't exercise, they drank, etc. And they became insulin resistant. So you would obviously be at a 25% risk. Could that be prevented through your dietary and lifestyle? How much would that then reduce that percentage, or would it not? Would it still be 25%?
It would absolutely reduce it.
Oh,
with
okay,
lifestyle
cool.
change. Because again, your genes are not your destiny, because, you know, the choices that you make with the lifestyle could either switch on or suppress that gene. You still have that risk. That risk is always going to be there. But the thing is, the more consistent you are in doing the things that would trigger, you know, that risk, then the better you are for it. And you can never go wrong with it, because in addition to preventing diabetes, you're also preventing so many other issues like heart disease, cancer, you know, and so on. So why not do it? And it's something you have to do without a pill.
No, 100%. No, that's really interesting, because I did my dissertation and my master's on type 2 diabetes. So a lot of everything that I learned there was on that. And before I became a coach, fun fact, I wanted to go into clinical work on type 2 diabetes, actually.
It's not too late. We're still
yes, that's true. I could try. But I just found it so interesting it's so weird to say it's interesting as a health related disease, but like it is quite an interesting one, because it can be so preventable. Like obviously type 1, as we know, is not, unfortunately. But type 2 is really highly preventable. And Zach's uncle actually has type 2 diabetes purely based on his genetics, but he's managed it so well that he's massively reversed it, and he's barely on like any of his medication now. So it's definitely possible within some people. But sorry, just kind of going back to your practice then, like tell us a little bit more about your like holistic approach to kind of medicine then, and just kind of what kind of got you into that route, like what wanted to make you, obviously you just mentioned about the time, the concise of the time within the NHS. So what made you want to kind of delve into that sector over just staying with the usual, like, you know, come to the doctors, get you your prescription and then leave type?
So just that. Like, that part, like, you know, that part of, you know, I just, that idea of, okay, this is a prescription for this, you know, and that's the end of it. No, I think for me, one of the things I've learned is once you provide education to people and they understand why this is good for them, this is not so good for them, and this is why they need to do this, and this is why they shouldn't do this, and this is why they need to take this, and this is why they shouldn't take this. It just opens up this world where they're more empowered. So I think one of the reasons why is that to empower my clients, to empower them to understand their health, to understand their individuality. Like this is, you know, this is who you are. This is what your genes have given you. This is where you are in life, because, you know, you're a woman in your 40s, you know, you shouldn't expect that you're going to be the same person you were in your, you know, 20s physiologically. You know, things change. You should understand why they change. And if you understand why they change, then you can either, you know, do things to improve yourself overall, or to accept some of the changes, you know, that you're experiencing. So that empowerment is important. And then I think as well, when it comes to like health, it's not sort of like I don't want it to be like a revolving door. It's a journey, you know, and as you're walking, you know, the seasons change, you know, everything changes, and you understand why you might be having this knee pain, even though you've been running 5 miles every day for the last 3 years. Your joints will wear and tear. You will have pain. It doesn't mean that, you know, there will be damage, but that damage doesn't mean that is the end of running for you. You know, you can still do it, but maybe you just have to be more mindful. Maybe you have to make some changes when it comes to muscle training, you know, just things that to be in my mind should be sort of logical.
Yes, so, I get that. And I think I can really relate with that.
Yeah, so that logical approach.
We definitely 100% have that same outlook in life and in fitness and in overall health. And what you were just saying then is definitely like ticking the green flags in my head of how I even like think and have that approach towards like fitness and health. I think it's so important for even just like, it doesn't even have to be where people are training, you know, 5-6 times a week strength training. It could be where people go 2 days a week strength training, 1 day yoga, 1 day swimming, but it's like they're actually just or even if you just walk every day, you're still doing that point of movement and you're still actually getting yourself out there and active. And that in general, just that can just help towards reducing these health-related risks, which is so, so important. So like you obviously, of course, work within the system and then like kind of your practice as well. If you could just like change, you think like one thing within the system, what do you think you would want to change within it? Or I guess like now that you've been in your private clinic for yourself and you also still work as a general practitioner for the NHS, like what is it that you can like what's the discrepancy and what could you want to bring into it? I mean, apart from the obvious like funding. So bring us all the money, people.
That's a hard one because, I would say perhaps focusing more on health education. From the onset, from a young, health education, and not just like, it's not just PE. No, it's, making children understand why they need to have, healthy food. And, making them, empowering them to make the right choices, not just like saying, okay, you must have a fruit every day, but just, I think education, not just from a young age, but continuous education. Over, different stages of life. Because one of the things is that it's so easy for us to access, I suppose, what's the word? Poorly nutritious food that's, very tasty.
It's so much cheaper.
It's so much cheaper as well. So I guess another thing would be to change the environment around that. But if we are able to empower ourselves to understand that this isn't what we want, then perhaps the environment would also change as well. Long term. So I think education.
And like you say, that's such a cycle of like, we need, like you say, better education in schools to then teach these children. So then these children can then learn and grow up knowing these facts. But then it's also, like you say, like a money situation with getting people to be able to afford that food, or the accessibility to it. And then it's like the constant kind of cycle.
But you see, at the end of the day, the system who make these decisions to make it that create the food environments, these systems are created by human beings. They choose, but then if those human beings were properly educated on
that's so true
on the damage that the current environment is making, then perhaps they would have a conscience and do the right thing. So perhaps I think you can't go wrong there. Education. It will take a lot, but it's not impossible. There are countries who have achieved it to a certain degree, like Japan and
I was actually listening to a podcast a few, I think it was last week. And I don't know if you ever heard of Rhiannon Lambert, but she's like a registered nutritionist. And she was saying that in Spain, they've banned ultra processed foods in all their schools. Like all their schools have no ultra processed foods anymore, which I think is incredible.
That's amazing.
And I don't think the UK will be too far behind, in my opinion. I feel like we'll look at that and be like, okay, there is a child obesity crisis in the UK. What can we do about that? Well, the number one is the school. And obviously, I think it's amazing how schools have free meals for kids. I think it's incredible. And I think it helps a lot of families out. But obviously it's the foods that are the unhealthiest and the less nutritious that end up being free, which of course is going to be the case. And I'm not saying kids should not eat their dinners, obviously, but if that kind of rule from Spain came into the UK as well, it will massively help. Massively help children. And even just thinking about when I was in school and after school, people would go to the shop and just buy loads of sweets with the money that their parents give them, or they might not spend it on their dinners, but they'll spend it on sweets and energy drinks in certain shops. And even I have been quite educated from I wasn't necessarily educated, but quite thoughtful of food from a very young age. That even I used to be I'll get myself a few sweets and stuff like that. And I remember even just even that in general, it's like, it's so easy to be like that and do that. And then it stems and then it gets worse. And then even getting into like teeth decay and stuff like that. We could talk about that for ages. So that's quite interesting. And also something that I definitely agree on 100% about the educational point. And that's what we really try and like master at the Game Changer. As you know, it's just about like educating people and getting people to like fully understand why nutrition and food is so important. Because even we get the opposite of where people come and they don't eat enough food and they're not eating enough protein and enough of the right foods. And that in general can then cause a whole lot of other health related issues.
It's still malnourishment. So malnourishment from overeating and undereating. It's all malnourishment. So you just have to get it right. So I think education, I would say. You can't go wrong there.
No,
if there was one thing, there are 101 things.
Oh yeah.
There was one thing.
101 things. Okay, cool. So just kind of moving on to like a next topic, which I feel like is definitely going to be a good one for a lot of females, especially the females that are in our gym. And I know you ladies are listening to this podcast. Menopause. So as you know, we have a range of women from ages like really young to like my age, around like 20s, but mostly the dynamic of the females in our gym is around 37 to about 55-ish, and then maybe a couple older than that as well, who either going through menopause, are perimenopausal, or have been through it. So as we know, menopause, obviously we lose estrogen, then we can lose muscle mass. It can slow down our rate of losing weight and stuff, hormonal balances. And obviously this is what you specialize in. So firstly, could you just maybe touch upon, just for then listeners to know, because obviously you've got way more education in it than I do, just about how menopause can affect a woman in their life, like what can it actually affect mentally and physically? And then we'll kind of delve a little bit more into, I guess, like what exercise can be doing for it in terms of treatment.
Okay. Well, so when it comes to the perimenopause and the menopause, it's essentially a physiological state. Every woman on earth will go through that in their lifetime. And the journey from the perimenopause to the menopause could be up to 10 years.
That's so shocking.
Up to 10 years. Imagine that.
And every woman has so many different experiences.
Everyone has a different experience. And those experiences could be determined by a lot of factors, part of which could be the environment they live in, or where they grew up, or their genetics, or their lifestyle. So all of these things can contribute to it. So no two women will go through the same journey, right? No. And once that journey starts, imagine you've got like an engine that's sort of like trying to continue moving, and it's like revving and then going out and rev and down, up and down, up and down. So you're going to have these periods where things are kind of like going smoothly, and then the engine kind of goes, whoop, then it goes, revs up again. And so that's the perimenopause. That's where you kind of start to have those.
You're aware you've got symptoms coming.
You're aware you've got symptoms coming. And that's where you've got the estrogen deficiency and things. And when it comes to estrogen is an important hormone for the entire body. You have receptors, estrogen receptors in every cell from your head to your toe.
Interesting.
So it's not just about estrogen in like the, pelvic area, gynecological structures, but you've got receptors in your lungs, in your heart, in your gut and everything. That's why when women are going through the perimenopause, sometimes all of a sudden you notice, they're starting to have more bloating symptoms or more urinary symptoms, or they're more achy and so on. Of course, the muscle mass, loss of muscle mass is one of it. And then also what happens as well is that the fat distribution changes, wherein before menopause or perimenopause, the fat distribution sort of was around like the hips and the boobs and the butt, but then everything then shifts to the belly. So so it's that change that sort of makes it difficult.
And what's the just to interrupt, what's the science behind that? Why does it go to that
It's
section?
just physiology. It's just sort of like, if you think about prehistoric days, so like during the peak fertile years, you need a lot more fat around the pelvic area, so that you're able to carry your babies, deliver them. So it's just more about evolution. So it's just
That's insane.
how we're just designed.
Yeah.
But again, the things that could affect it, as I said, your genetics. So for example, if a woman has a sister or mother that went through menopause or the perimenopause earlier on in life, they may start to experience symptoms much earlier than other women, for example. The typical age range, or should I say textbook range, that we've been taught is somewhere from like between 45 to 55 for that 10-year gap. But there are women that could start experiencing the symptoms in their 40s.
I think I know someone who was 37.
Yeah. So in ages like that, we changed the definition to premature ovarian failure. So it's not, it's the same concept in a way, because the ovaries are failing, but in the perimenopause, the ovaries are shutting down because we expect them to shut down.
Would it still be, so let's say someone started their, I'm not even going to try and say what you've just said then, that pre-failed, whatever.
So let's just say like the ovarian deficiency.
Okay. If they started at 37, would that still last over 10 years then? Till like they were like, would it even last even longer? Or would it still be that kind of range of 10 years?
It could be that range, but because theirs is sort of like a pathological.
Okay.
So it may be accelerated. It could be, it could be a slow rate, but you can't tell. But because theirs is quite early to expect it, then it's addressed in a different way.
Okay. And is that mostly genetic to why that would happen? Or is that like what could be, I mean, I'm not going to say any lifestyle choices would bring that on for say, but like what could be reasons to why someone may start their menopause quite early?
Well, actually, lifestyle can play a role.
Oh, right. Okay.
Things like smoking, alcohol, excess weight, they do play a role. Genetics for sure, because say, for example, as I said, if moms, especially mothers and first degree relatives, moms and sisters, we did go through it early on, then it could be the same. They're more likely to. But lifestyle does play a role. Environmentally as well. So the environment as well. So if you say live in like an environment that's sort of like polluted and things like that, all of those things could contribute to it long term. But that's why some of these things are difficult to sort of navigate, because you don't sort of grow up in an environment thinking, oh, I'm going to go through the...
you don't know.
You don't know. And it's just, it's not as easy to control some of these.
No, that makes a lot of sense. Yeah. So in terms of just like how the menopause affects a woman when they go through their like everyday life, training, work. Can you just delve a little bit more into that, like what are the actual effects of it and how it can make, because I've listened to so many podcasts and I know like women can go through like suicidal thoughts, and it can be such a big thing in their life and a huge change, that I really hope males are actually listening to this, so then you can learn about your partners and like your sisters and your mothers and stuff like that. Like listen up, because this is going to be interesting.
I think the awareness around the perimenopause and menopause is changing significantly in the last 5 years. It's changed so much. There's a lot more awareness. People are more accepting of it. It used to be like this stigma of, what the heck's going on? Why is she acting crazy? And there was just this focus on sort of some of the, I would say, physical type symptoms, the irregular periods you get, the hot flushes, and maybe the muscle aches and pains. But it's beyond that, like you mentioned, like the psychological, effects of the perimenopause. So things like the mood swings, the anxiety. There is this thing what I hear a lot now, brain fog.
Brain fog. That's all a big one.
And then you've also got some of the other physical symptoms, because as I said, you've got receptors head to toe. So women complain about changes in their hair, their skin texture is terrible, or gut health is worse than it was ever. They feel more tired, but that could be because they're losing muscle mass, and as well, sometimes you also get, other just unusual symptoms. Some women could just say, look, I have a crawling sensation on my body, ringing like sensation, itchy skin, all sorts. So I think the symptom range is so wide. So that's why it's never it's never enough to just say, well, it could be menopause and just dismiss it, because it's not going to go away.
No,
it's going to continue. That phase is going to continue until they get to that one day where the ovaries say, actually, I'm done now. They just shut down. And that is just one day. That's the menopause.
Really?
That is one day. It's just
one day is literally just the menopause, and then the next day you have no more symptoms.
No, not really. You will once the ovaries stop producing, then you still have some of the symptoms of like for example, the effects of the estrogen deficiency. So the while you're going through the menopause, the deficiency is ongoing. You could have a little bit produced hair. You're coping, doing what you can, but then one day it just stops producing it, and then when it stops producing, you're either dealing with the aftermath of the deficiency you've had for the last 10 years, or some of it could continue. You could still get muscle aches and pains if by then your woman hasn't developed things like arthritis and stuff. You still could experience issues with, say, your gut, issues with breathing, issues with the heart, so many things. So but it's for anyone to go through something like that for a decade of their lives without getting some kind of help. It's important. I don't know how, people used to do it in the past when there wasn't a lot of awareness on it, but
like you say, I genuinely think it's only quite recent that even just women's health as a whole has been, because I listen to loads of podcasts and even when I was at university, most research into everything is done on males. I think actually there's 2%, I listened to a statistic saying 2% of research is on females and the rest of it is males and animals. And I was like, how do people know a woman's body if they cannot be researched on?
And that's why there's still a lot to learn, because even the approaches we have now, even though yes, we have more options in theory, or we have more options to manage it, it's still based on old research. So we still need new research to see how much further we can go. There are probably things out there that people are currently trialing, or people are doing. So anecdotal evidence to suggest that certain things could be beneficial during this process. But because everything has to be backed by evidence, science, and it has to be robust, and it should show that it's more beneficial than risky, it's all of this, the progress is going to stall.
It's going to be in 10, 20 years time where we're going to be like, well, listen to this podcast. It's not 2% anymore. It's actually 4. And just a question, just while you were talking about symptoms and stuff. So obviously I have people around me as well, family members and stuff, who are all gone either through the menopause now. Now, typically at a point throughout the month, they will say I feel like I could have had my period now. Once you've kind of gotten through the menopause and you're not necessarily having your PMS symptoms anymore because you don't no longer have periods. And like you say, maybe, we're not actually carrying any more brain fog or anything like that. Is there still a point in the month where a woman could feel like placebo effect, their period would be there? Is that true?
Yeah.
Because I've always been is that a thing that we just think because we're women and we're just overthinking it? We're we could have had our period this week. This is what I'm feeling like. Or could it be more of that's actually true?
No, absolutely. You still can, because you're also going to be having the low level, because don't forget, estrogen is one hormone. There are other hormones that we produce. So some of them could have similar effects.
Interesting.
To the estrogenic effects that you perceive could be from other hormones as well. So it could still feel that, that feeling, I guess, what's the word, achy or just
almost like you're because I some of my symptoms, honestly, I put it on my story a few weeks ago. I'm just a different person before my period. Literally 5 days before, I'm I have depressive symptoms, sadness. I just get this wave of thfeeling so sad, anxious.
Those are your hormones.
And I'm oh my gosh, things. I love being a woman, but this is the worst part of being a woman, is this discrepancy in my mood. Zach's always are you okay? You woke on the wrong side of the bed. I'm
no.
Don't talk to me. And I'm I hate you. I hate this. I hate that. And it actually sucks. So even just thinking about what women go through when they go through the change, that their symptoms must be 10 times worse than just regular PMS symptoms. And obviously, as we know, just speaking about the women at our gym, because they train quite regularly, they might have days where, you know, they do struggle. And we always go like, what's your battery life today? And they'll say like, oh, I'm at about 20%. I'm having these symptoms, that and the other. How important do you think exercise is for women then, as a whole? And then also those going through their menopause?
Super important, because once they start to go through that phase of estrogen deficiency, as you know, like muscle mass is down, bone health is sort of, you know, declining a bit. So the best thing you can do for that is to work towards increasing muscle mass. And that's by doing, you know, strength training exercises a couple of times a week, increasing like your protein intake as well, reducing, you know, things like alcohol, cutting out smoking, and just sort of like optimizing your nutrition, you know, and then focusing on the exercise, because in addition to the direct benefits, there are also the indirect benefits of that as well, you know, in terms of cardiovascular health, you know, brain health, kidney health, and gut health. So it's super, super important that it's, you know, it's the moment that struggle starts, where they feel like, oh, I don't feel like I am as strong as I was when 4 years ago. That's because you're an entirely different person physiologically. Forget, you know, forget really that part. It doesn't mean that you're not doing enough. It's just, that consistency is
your
where,
body's just changed.
Your body is changed, but you just need to be consistent and work with this new physiological part of yourself. You know, everything is changing. And then I guess the acceptance is important as well. So,
which is quite hard.
So maybe that's where you need to get, you know, additional support through like support groups or menopause-based therapy and so on. So if that you could get, you know, within the gym or outside the gym or wherever. But that's where it's important, because that understanding and acceptance of it is absolutely critical. Because so what I sometimes see is that when women find that, oh, they're starting to, you know, have a different weight distribution in places they don't want it, they kind of almost give up on the exercise. They're like, what's the point of doing it? No, that's when you should do that. Focus on. That's when you should start or continue, or just, you know, just keep at it. Because once you stop, it's, you know, the long-term loss is you're going to lose out on so many benefits that you could have gotten from keeping consistent with the physical activity. And again, I do sometimes find that there is this, I don't know, I think it's maybe just the society where, you know, people see what other women have achieved, you know, how come she's still so fit in
comparison is a thief of joy, people.
I know. And then
thief of joy.
And then this focus on, I don't believe that a person's life or well-being should be focused around what it is that they weigh, you know. It's that obsession with, I just don't get it. I feel like if you're able to sort of remain consistent in the level of physical activity, you know, 2 days of strength training, at least 150 minutes of moderate intensity exercise every
just
week.
The regular,
just the regular consistency. You cannot go wrong with 100%. That, because it's beyond just the physical. You know, it's future proofing your heart, 100%. your lungs, your kidneys. Because without those organs, you know, you're never going to live to enjoy 100%. The later part of life. So the consistency is what people need to sort of lock in to get that. And in a way, I feel once you start to do that, you may even start to appreciate some of the little changes, little things that maybe you didn't think was important. You know, maybe grip strength, for example. You're able to carry shopping bags in one go.
I love that.
You know, like,
that's such a non-scale victory. I'm like that all the time.
Like carrying it, because some of the changes you're preparing menopause, for example, like, you know, muscle strength is weakened, so you have things like more shoulder pain, more like issues with like the knees walking up the stairs. But then you realize that, oh, you're doing this quite easily
without even thinking about it.
So the little wins are just as important. Just as important.
And I think as well, like, obviously, as we know, like, as we say, movement is therapy and movement is that medicine. And I think psychologically, like, it helps people massively with their mental health during the time of the menopause. As we say, we have all of those psychological effects as well. I remember speaking to one of the members who she actually had the early onset perimenopause. Yeah. I can't say what you said before. Ovarian
failure.
Yeah, ovarian failure from the age of 37. And she actually said that before coming to the GC, she was on HRT and then she came off it because it just wasn't suiting her body, which again, everyone has different experiences.
Different.
My mom didn't really have the best experience either with HRT, but she was basically saying this member that the GC to her is her HRT. It's like her therapy change. Like it's massively helped with her mood swings and her brain fog and her productivity and her focus.
Yeah.
And I just think that was amazing for her to say, because you don't even think, or women don't think about those things. Do you know what I mean? Like women, we know women and we know that we're all about the way that we look and what does the scale say? And do we fit in this size of something dress? Like, so I think it's really important, as you say, to look at those smaller wins, those non-scale victories as a way of being like, no matter when you start, like my mom's only just started going to the gym now and she's been through menopause, I think for a good like 4 or 5 years and she's only just started. So you're not even too late to start, even if you are. I mean, it's going to be a lot harder, as you say, like it's not having that consistency before, but hopefully building consistency wherever you are in whatever point.
You can never go wrong. You just can't never go wrong with physical activity. Like, you know, the benefits, you just can't go wrong.
Unless we do too much. Then we
unless you do too much. You don't want to go too much. You don't overtrain. But you know, coming off of what you just said about the HRT not suiting everyone. HRT doesn't suit everyone. It's not for everyone. As a matter of fact, the guidance on how best to manage the perimenopause always starts with like the simple things, you know, like physical activity, menopause therapy, you know, cutting out lifestyle changes. That's actually what's in the guidelines.
Well, I remember me asking you advice for like a family member of mine that was going through something with like PCOS. And I remember you saying like, well, could you let me know like what are these symptoms, this and do they do this and do they do that? Because if not, they're not going to be eligible for help and you know, they need to go down that route first before they go in, which I do think is really actually quite good that the NHS has that as their list, because they could easily just go, yep, here's this pill or here's this medication, and then like you say, putting a plaster over it, rather than actually thinking, okay, what is the root cause of this and how can we help before giving any sort of medical advice and stuff.
So the guidance is beautiful, you know, it's there. It says, okay, encourage physical activities, strength training, encourage therapy, this and that. But resource-wise, you know, for example, anytime I present the case of, this is what you need to do for that. Some people will say, yes, I'm already doing physical activity. I'm like, okay, maybe you need to optimize it in this way and, you know, maybe get more strength training in and blah, blah, blah. But then the other sides of maybe understanding the psychological sides of things. It's so difficult for people to accept it because I feel there is a stigma around, you know, sitting down and talking about your feelings sometimes. Plus also having the resource easily available. If I told a perimenopausal woman, you know, struggling with like the psychological side of things to wait, I don't know, 16 weeks before talking to a therapist about
that's
menopause,
very true.
and she's going to slap me in the face and tell me, give me that HRT before I kill you.
So, that is so true.
So unfortunately, the you know, availability of the right resources could also make it difficult, which is why sort of pushing a prescription could sometimes be not the easy choice, but the only choice at that point in time. For some
well,
people.
It could be where they go on it for X amount of months, as you say, but at the same time, they start to train. They start to walk more. They start to eat better. And then actually they can be like, I can come off this HRT now and I don't need to be on this prescribed medication. Or even just give it a go of coming off it because they know they're doing those things. Do you know what I mean? So I totally agree that it's like anything, isn't it? It's like being given any sort of medication to help something and for it to be preventable then. But then eventually coming off it when you know you're at a better point. Do you know what I mean?
Yeah, and that's the whole point of it. Because any woman, because I treat women with the perimenopause and menopause, and I do, you know, start women on HRT when they want it. And I always say, look, I'm not curing anything. This is just about symptom control. You know, sometimes they ask, so how long do I have to be on this one? I'm like, it's up to you, because if you're able to do the other things that would help the process, then it's you know, it's up to you. We're just managing symptoms. We're not curing.
No.
Nothing we're curing. It's
helping to ease the...
It's just to ease the burden of the symptoms, so they're able
symptoms.
to at least have a good quality of life. Medium term.
Because it affects everything.
Yeah, it affects everything. Yeah.
So yeah, that's really interesting. And I guess touching on medication and touching on specific drugs, we're actually going to talk, and Jake and I spoke about this on the previous podcast and kind of gave our thoughts and our opinion and just kind of shared, but we would love to get a medical opinion of it.
Yeah.
Obviously, as we know, Ozempic, Mounjaro, weight loss jabs, they've become very mainstream. Yes. I would say like a lot of the population now know about this specific drug.
Yeah.
And I think I saw a statistic by like 2026, like 7 million people will be on it, which I think is absolutely horrendous. Well, not horrendous, I shouldn't say that, but like shocking to say this. So what is your opinion on Mounjaro and Ozempic? What are your thoughts to begin with on it as a drug? We know that it wasn't obviously specifically made for weight loss. It was made for those with like type 2 diabetes, inflammation, etc. But it's gone on to now being more of a weight loss tool. Yeah. What's your opinion of it?
So I think these medications have a place in the management of obesity as a disease, because now we know obesity is a complex multifactorial disease process.
Yes.
Right. And these medications are perhaps the lifeline for people who have lived with the obesity or the complications of obesity throughout their lives.
100%.
Yeah. And you're right. They've been around for a long time. They've been around for over 20 years.
Yeah, that's insane.
Over 20 years, yeah.
And it's crazy how they've literally just within this last year gotten like
because
popular.
I think, so they've been around for over 20 years. And yes, initially the class of medication used to be licensed for management of diabetes because of its effect in regulating, insulin, the blood sugar and things like that. So I think as part of is actually a side effect. The weight loss was a side effect of the medication. So it was kind of, this is actually really good. And then I think the more studies were done on them, it was realized that, actually, this could actually help people who don't necessarily have diabetes, but have issues with excess weight.
Yeah. And
that was how it came to be licensed for the management of excess weight and or obesity. So they have a role in managing the right type of patients.
Yes, I agree with that.
Simply because when it comes to obesity or excess weight, it's not just about the weight that a person carries, okay? And it's not just because of what they've put in their mouth or how little or how much exercise or little exercise they do. It's so complex, genetics, you can't underestimate it there are actually studies to suggest that the preconception weight of an individual's parents could determine whether or not they're at risk.
I remember reading that.
Whether they're going to be obese or something.
Yeah,
so
totally.
That's one. Then you have things like hormones. So hormones, for example, things like thyroid hormones, estrogen hormones, and all of those things have a role in weight. So if we're managing, if we have issues in those areas, and then we're focusing on just giving you a jab to relieve excess weight, and you don't manage those problems, then it's not you're never gonna win.
Totally.
Then you also got things like the effects of age. As we age, we lose muscle mass. We sort of start to distribute fat in different places, and it's just evolution. It's just how human beings are. Then you've also got the environment that we live in. Unfortunately, a lot of the European environments, including the UK, obesogenic environments. You've got easy access to fast, unhealthy foods, lots of processed foods. Certain environments have little access to sort of areas, where people can walk, or we're living more sedentary lifestyles, sitting by our desks and things like that. And so you have all of these factors coming together. And then, if we then now just focus on giving a medication without addressing the effects of these other factors, then we're just, again, putting a Band-Aid on something.
Totally.
So I know that at the moment, the medication is available for weight loss specifically, and at different doses. It's also available on the NHS. However, because of the constraint of funding, or because they are expensive medications, the criteria is very, very strict. Okay. Which is good. However, what I find interesting is that the criteria before a person can be given the injection for the weight loss is basically until a person has some of the complications of excess weight.
Okay.
Specifically, I think at this time is like hypertension, sleep apnea.
Would they look at like waist to hip circumference and stuff like that?
No, not that. So
like the actual
diseases. So there are certain diseases for you to be eligible. You need to have at least, I think, 2 or 3 specific diseases plus and a BMI, which is a crude way of assessing body fat percentage, and a BMI I think of 35 or 40 or something. I can't remember specifics before you're eligible for the injections. But the funny thing is that people are already suffering with these complications. You would want to go in to manage excess weight before these complications set in. But I suppose the rationale would be because of lack of resources to do everyone. And from what you said about the statistics on like over 7 million people being on the injections in the next few years, that's because we're in an obesity epidemic.
Yes, we are.
And that's the reality of things. But on the flip side though, because the medications are now so popular, I know that people are able to access it privately through channels,
the black market, I'm sure.
Through channels that are relatively questionable.
Yeah.
So I could sit in front of a computer. I think I tried it one time and I thought, oh my God, this is super dangerous. Yeah. I just clicked.
And how do they know they're getting the actual drug?
No, exactly. First of all, how do they know they're getting the actual drug?
Yeah.
And then say, for example, let's assume this is someone who this is a pharmacy, I don't know, a company, a pharmacy or a clinic who prescribes a drug remotely, whatever. And then how do they know that the person providing them the information and giving them the right information?
Yep.
Because some people could have underlying health problems. So someone who's got issues with an eating disorder or has a serious mental illness.
Yeah.
And then, their obsession is about losing the weight, and then they just put information online, lie about
like how big they say that, I'm eligible because I'm this and that.
And then next thing you know, they're being dispensed this medication and then they're taking it and, it's just, I don't know.
That's the scary part of this.
That's the scary part of it. So I think with medications like this, anybody who is taking it, they need to also make sure that they are getting the right support, wherein they're looking at all the other associated factors that could be contributing to their weight gain. Because it's impossible for somebody's weight gain to be because of just their lifestyle. It's impossible. It's just it's all the other factors play a role one way or the other. So those aspects 100%. Need to be explored and addressed, because otherwise where's the end point? Okay, because yes, it's a chronic disease. There are certain groups of people that may need to be on these medications long term, but there are people who are using the medication because they want like a quick fix and then they stop it. But then if you're using it for a quick fix and you're just stopping it, what do you think is going to happen you've not built any
sustainable habits
to change to show that, to ensure that you're not going to regain that that weight. And because we're in relatively new medications, in the sense that with the newer ones, of course, we're learning more and more about some of the side effects that people have experiencing with it, and we're going to keep learning about that. I think at the moment the side effects are underreported in this environment because a lot more people are getting it privately. And in the private sector, the reporting might not be as robust. So there may be complications that people are having, but we just don't know. So in another 5-10 years, we're gonna.
I think from just like when I've looked at it, a lot of people have like the side effects of potential like tiredness, nausea, like vomiting, like fatigue and stuff like that. Which I'm like, oh my gosh, I would not want to put my body through that.
So you see, that could be as a consequence of not having guidance when you're having the medication. Because one thing that I have,
that's actually my next question.
Guidance of not having guidance when you're taking the medication. Because say, for example, somebody wants to be on the medication, but they think, no, I don't think this dose is going to be enough. This is just such a little dose. I need to go up, straight up. And then, next thing they're jabbing themselves with sort of double what their body can cope with. And of course, you're going to have side effects. And again, we don't know what that person's baseline is. Say, for example, someone with excess weight, maybe they currently have issues with, I don't know, gallstones or something, or pancreatitis and things like that. If you're taking that medication, you're probably likely going to, you know, make yourself more unwell with it,
isn't it? Yeah.
The side effects of like the nausea and the vomiting and things, and that's kind of one of the ways the medication works, because it slows down the gastric emptying. So you eat food and then it sort of, say for example, we expect that the food is supposed to leave at maybe 15 miles an hour. With this medication, it slows it down to 5 miles an hour. So you're feeling fuller for longer.
Yeah, because it suppresses the appetite.
Suppresses the appetite, exactly. So maybe a person who may have underlying gut issues, you know, maybe irritable bowel or something, if they then start to take the medication without the proper education and preparation, then they're going to have more of the side effects.
Yeah, that's so interesting.
Not having the right guidance before you start the medication can set a person to fail and then to suffer with lots of complications, you know, further down.
And I think that was kind of going on to my next question, was like, so do you believe there is a way that this can be done safely under the influence of like yourself as a GP and a professional, and then us as like personal trainers and like nutritionists, etc.?
Absolutely. Yeah. Because again, the medications are excellent. They're good medications when used correctly and for the right patient. But I think, again, yes, having the guidance, you know, expertise, nutritional expertise, you know, having a proper health screening, you know, having a proper exercise regime, all of those things play a role. So, for example, when a client comes to me, you know, I spend at least an hour before I see them going through, you know, their health questionnaires.
Is this your private?
This is for my private. So this is an hour beforehand, looking at probably sometimes not an hour, because I have to sort of look at the different factors, because they go through like a very long, comprehensive screening as well, you know, looking at the physiological things, genetic things, environmental things, looking at everything, look through that. Then we then have like a full 1 hour consultation, discussing, going through, you know, some of these things, exploring even just down to like even childhood, understanding their relationship with food, their relationship with physical activity, what their limitations are, what they've tried in the past. Because no one with excess weight or no one who's obese can say that they haven't been trying to lose weight. It's perhaps something that they are constantly thinking about 24/7. Every meal they have in front of them gives them this anxiety about, is this going to, you know, make me gain an extra kilo or something? So, but you see, I don't think it's right that a person's life should be, you know, should I say, controlled by what is this that so we sit down, have this 1 hour consultation, and after that we can then say, okay, this is where I think the issues are, and this is where, you know, we could get you on track,
find the root cause,
find the root cause,
create the system,
and create. Exactly. And then, you know, in every situation, there's always going to be a need for changes to, say, nutrition. Okay. Which, you know, a lot of times I can give them some advice on, okay, this is where you are. This is what your BMR is. And this is what you, this is if we want to have X percentage of weight loss over X number of months, this is how we need to, you know, do a calorie
deficit.
Very good. So kind of break it down that way.
That.
Physical activity, sometimes for some people, they are already doing some form of physical activity, but maybe they just need to optimize it in a way. So some people are busy mums and things, they don't have time to do. And I say, well, why don't you, I don't know, park the car 10 minutes further and take that extra 10-minute walk. I have a client who told me that she's got a treadmill at home, and she struggles with getting on the treadmill because she has to wear a gym outfit. And I'm like, why don't you, she's got together, why don't you make it like a game for your kids to say, anyone who puts her gym clothes on her treadmill, you know, gets a treat or something, and then it's there, and then she can just go next to it, wear it. So just, you know, sometimes it's just those simple incentives to go for. And then of course with the medication, when we do, and if we do go forward, it has to be started at a safe level, and then optimized over several months, you know, because they work for the weight loss, but if you are losing weight but not doing the other things to improve on the lifestyle, because the medications allow you lose fat, but they also cause you to lose muscle.
Yeah.
So if you are on these medications, you're going to have a reduced appetite, but then you need to make sure that when you do eat, you're eating the right stuff, like high protein diet, so that the high protein diet with proper strength training would ensure that you are building muscle. And the more muscle you build, the more calories you're able to burn.
Exactly.
You know? And then
high
metabolic rate. And then the more you have a high metabolic rate, then the fitter you are, you're more conditioned, and you're more likely to succeed long term. So it's like a long term thing. It's not, we're not doing it just for you to lose the numbers on the scale
for a holiday.
No,
Exactly.
Not. No, it's a journey. So it's about changing those habits long term. Once we're able to achieve that, then we can, okay, this is good. This is where we are. So should we start thinking about, either stepping down on the medication, or do we think about if it's a situation where a patient tries to step it down and they struggle with maybe the eating habits, we can stay on a maintenance dose, because at the end of the day, it is a chronic condition for a lot of people. So it's just like somebody having, high blood pressure or diabetes, they would need some form of treatment. Sometimes we step up the treatment and sometimes we step it down. So that's the approach we take. But, I feel it has to be done in a structured way, not just going online
and just Googling it. No. I totally agree. And I think like you just said, then there are many pros and cons against it. I don't know whether there is more cons than there is pros. I'm not too sure. But at the end of the day, and this is another podcast I was listening to when they mentioned about how the relief on the NHS that the medication is given, because it's allowing people to lose weight and then not come to the NHS with these other metabolic syndrome, health-related issues, etc. It does put that, I guess, less pressure off. But then, as we know, and I think there's been other research now coming out about the actual medication then, giving other risks to forms of like cancer and stuff like that. I don't know whether you've seen that research out. I think one that I was watching online, like it came from like ITV News, but they were saying like it was like related to like thyroid cancer and stuff like that, which I don't know how true that is. Do you know what I mean? It's such new research that it could just be like.
Well, with this medication, actually, the one absolute contraindication is anyone who has a personal or family history of a specific type of thyroid cancer. So it's one called a medullary thyroid carcinoma. So it's a very rare type of cancer, but it's a very specific cancer. So anyone who has had a family member, a first degree relative that's had that cancer, or they themselves have suffered from that cancer, is an absolute contraindication. But in terms of the risks on causing other cancers, no, even within thyroid cancers, you've got about 3 different types. So out of the 3, just this particular one is the one that causes an increased risk. But I think when you look at the pros of the medication with cancer, the obesity itself
will cause more.
The risk of obesity and cancer in a lot of the, like breast cancer, stomach cancer, lung cancer, prostate cancer, endometrial cancer. Obesity is probably the number 1 risk factor beyond like smoking and stuff like that. So if you're talking about benefit, I would say
in actual fact,
that is
actually and then I think I saw on the other flip side of that the medication was helping to reduce cancers.
Absolutely help. So it does.
So then I was like, where this is where research is so sticky. Do you know what I mean?
I think again, because we're now using it more, so we're going to be learning more about the medications in the coming years. So we'll wait and see. I guess it's sort of one of those watch this space type.
See what it's going to develop into.
I think recently there were certain like safety concerns around contraception in women, because for like women on hormonal contraceptives have been advised that they should go for an alternative form of contraception if they are on oral contraception whilst using the GLP medications.
Interesting.
And I think it's one of those logical things, because when you're on the medications, the gastric emptying time is slowed and then absorption is slowed. So I guess the idea is that if they're on an oral contraceptive pill, then it's less likely that the contraceptive is
that because
properly.
they say, because interestingly, and this is something that I'll share, when obviously like I'm not on contraception, never been on contraception. One of the reasons why I didn't go on it when I was younger was because I had an eating disorder. So the thought and what I heard along the grapevine of research was that obviously contraception makes women to gain weight. Because this was ages ago. This is what I believed ages ago. Because obviously it just increases one's appetite. And then obviously that makes people eat more, then calorie surplus, consistency, weight gain, whatever. So is that because of that contradiction then? So for example, if you're taking this Mounjaro, that suppresses your appetite, but then you've got contraception that then increases appetite. Are they going to clash?
Not really. So not in this situation. So in this case, it's more about the medication being available in your body to provide the contraceptive benefit because of decreased absorption. So it's more around that. So it's just the reduced efficacy of the pill itself. Because at the end of the day, appetite is going to be down because the hormone that it regulates it has nothing to do with the how the contraceptive pill works. It will still do its thing, but then it will try and stimulate the hormone, but the hormone's like, no, I'm not going to respond to that. So it's more about the efficacy. So reduce efficacy of the contraceptive pill whilst on the GLP-1 medication. So the recommendation is kind of to go for longer acting things like either the depot or the injections or the coil, whatever the other options that are available out there.
Interesting.
And to the other question you had mentioned about the pills causing weight gain. Yes, certain types of pills do. Some types do can contribute to weight gain because of what you said, like the increased appetite and increased sort of fluid retention and so stuff.
So like obviously because kind of moving on now to a little bit more about that, like Jake's always really a big advocate of getting bloods done and like, having a look into different like underactive, overactive thyroids. What's your hormones like? Have you got high estrogen, low estrogen and so forth? And as we know, hormones play a huge role, specifically in women on like their body, like depending on their body type, where they store their fats, etc. What do you think like I guess women could be doing that isn't just then necessarily going on to prescribed HRT or contraception? Would you say like it is just the exercise and the nutrition and anything, or is there certain kind of women? What I'm trying to probably say is that like obviously we're all different body types and we all have different things. Let's say someone has, is it like hyperlipidemia or something? Is that where we carry a lot of like body fat around our like hips and our legs? Is it called lipidemia? Am I right in saying that? Hypodemia?
Lymphedema or something?
Lymphedema, yes, I think I'm pronouncing that right.
So lymphedema is actually an entirely different condition. So that's more, I would say, a disease of the lymphatic system.
Right, interesting. Okay.
So that's different, and I think there is, women suffer it more, but it's more linked to genetic risks. Okay. If it's a primary lymphoma, if it's lymphedema without a secondary cause. There's lymphedema with secondary causes, which could be due to sort of things like, tumors in the belly, because if there's compression, then if there's pressure on the gut, then the pressure doesn't allow for the fluid, because lymphedema is technically just excess fluid.
Okay,
if that fluid is not going back to the heart to be filtered out and so on, so then you could have causes like tumors, things like certain medications can worsen it. Or in older people, there's just what we call incompetent valves, because with age, all of those things can affect it. So that's slightly different. But I would say, yes, certain medications can worsen it, say like the hormonal based medications can worsen it. So for example, if maybe a woman is at risk of lymphedema because of her genetic predisposition, then if she does start taking hormones, then it will worsen it. So it's not because of the HRT, it's just because she already had that risk anyway. Makes so that's what kind of triggered it. So it's slightly different. And I think that's why with these things is very, very nuanced. It's very individualized. And that's why before any kind of treatment is started, that risk assessment is done to say, okay, are you suitable for this? Could you tell me a bit about your family history? Have you suffered with blood clots before? Do you know of any mum or sister who's, suffered with blood clots? clots and so on. So that's why we do that risk assessment.
Yeah,
and
that
after
makes
the risk assessment, we can say, look, this is where we are, and this may be suitable for you or may not be suitable for you, or absolutely not for you, based on those risk assessment outcomes. So it's very, very individualized. But coming back to your question about getting sort of like assessed for like secondary causes, that's very important, especially in, say, women who are experiencing symptoms for the first time. Because a lot of times, when you do start to experience some of these symptoms, a lot of these symptoms can mimic certain types of metabolic issues and also even certain types of deficiency states. For example, metabolic issues like a thyroid issue, an overactive thyroid or an underactive thyroid can cause people to have mood swings, can cause people to have changes to their weight, can cause people to have issues with their gut. So that's important to check. Similarly, issues with, like, say, polycystic ovary disease. Polycystic ovaries it's actually not a structural disease. It's not a disease of cysts in the ovaries alone. It's a metabolic problem. It's an issue of insulin resistance. So it's a problem of your metabolic system trying to regulate,
very interesting. So similar almost to type 2 diabetes in a way.
Yeah. So because the effect of it is that there's insulin resistance, and that what causes weight gain and so on.
Yes.
But the presence or absence of cysts on the ovaries doesn't, you could have PCOS without having any cyst on your ovaries.
I remember you mentioning that to me.
So say investigating for things like that, looking at the patient's prolactin levels, testosterone levels, the sex hormones and things, all of those things can help to determine whether this is a metabolic condition like PCOS.
And is what's the right suited
through the pathway. I suppose with PCOS, you do see that in sort of younger women. So say in their late teens, 20s, 30s and stuff. By the time a woman is in her 40s, if she did have PCOS, she would have probably known that. Makes sense. Then you can have certain deficiency states. So things like deficiency in iron, B12, folic acid, so like the essential, we call them hematinics that you require in the production of healthy red blood cells, for example, because you need that to be able to sort of pump optimally, blood to your heart, your brain, your kidneys and so on. Because the body, it's interesting in that it will always prioritize these critical functions. It would make sure that your brain has all the blood that it needs. It would make sure that your kidneys get what it needs. It will make sure that the heart itself is happy. And that if you are say deficient in some of these vitamins, that you don't have enough of it. The body will then say, whatever is left, you guys just manage it.
Interesting.
So then that's why when people have deficiencies in iron, they might tend to be a lot tired. They're a lot more tired.
It seems to be. I mean, I know obviously like menstrual cycle, actually being on your period is where a common trait
one of the contributing factors, because if when you're in your period, you're literally losing blood and iron. If a woman has heavy periods, I'm an advocate for, if you have heavy periods and you know that's the thing for you, you're going to be having a period every month, just supplement yourself with, if you can't do it through your diet, then just have an iron supplement.
And is that would you say that's one of the main reasons why most women become anemic or like low in B12 and iron?
Very, very common. Iron especially. With the B12, it could be multifactorial, but B12, in addition to the issues with like the anemia, it can also cause issues with mood, because B12 is important for nerve health. So
interesting.
So sometimes some people might have, say, sudden low mood. They just can't really put a finger on it and stuff like that.
That is totally me.
So
maybe I should go get my blood checked.
Things like pins and needles and so on. So like symptoms of B12 deficiency.
Oh my God, that's so interesting. I'm gonna go get my blood checked.
Similar with vitamin D levels as well. So
and as we know in the UK, we don't get any sun.
So a lot of us have suboptimal levels or are deficient.
I think my mum was vitamin D deficient, which then most of it played a big role on like how then she was like, I explained a lot about moods and swings and stuff like that. So that's super interesting.
But with the role about, say, knowing about the like estrogen or the perimenopause and things, that's quite difficult to identify, because as I said, with the perimenopause, it's kind of like an engine sort of going up and down. So if a woman is in the perimenopause and she's clearly symptomatic, doing a blood test may not necessarily tell us much, because we could capture the blood test and then it could just be during a phase where it's considered
high,
normal, whatever. It's within that normal range. I think the benefit of a blood test would be, say, in a younger person where it's like, this doesn't really make sense, you know, that she's going through these menopausal symptoms, or in a woman who maybe has some form of hormonal contraceptive, particularly like the coil or something.
Yeah, interesting.
And she's not having any periods. We don't know whether she's perimenopausal or actually menopausal.
Okay.
Then we do the blood test and it can tell us, it can guide us to say, actually, you're more likely menopausal than
okay.
So that could help us. But in the other cases, the value is not as significant, just for the purposes of managing the perimenopause and the menopause, because we don't want a situation where a blood test is done and it's normal and the woman is sitting in front of me like clearly perimenopausal. Then what is it? So I say, look, it's you know, the symptoms is what guides what we do in situations like that, because the blood test, it's neither here
variable,
isn't it? It's variable. It's very variable, and it changes because it changes during the perimenopause, and the more it changes, then you know, so you can't really get it right until, for example, you say you want to be sure that she's menopausal. Okay, if she's menopausal, maybe the way you prescribe the medication or the way you prescribe the changes is slightly different. That's how much, you know, that's how much value we can get from doing tests really in those situations. Yeah,
I think I've only had like a handful of blood tests in my life. One of them was to check my iron levels, because I remember I was so exhausted at uni all the time. And I think out of like a score, they were like, your score is so low. They were like, how have you not come here and got tested before? And I was like, I don't know. I just kind of think, oh, I'm at uni, I'm stressed, I'm tired. You know, that's the kind of vibe. And they're like, no, like you're like on the baseline, like you're very low. I'm like, oops. So they give me medication. But I remember I had there's like 2 different types of iron supplements that they gave me. One of them was like, I can't even pronounce it, FF, and then there's FG or something.
So ferrous fumarate?
That one. Oh my gosh, that made me feel so ill. So ill. Like the symptoms of that I got off that, I think I had jaw ache. I think I had like nausea. I was so tired still. And I remember then they changed me to the other one.
Ferrous gluconate.
And that was fine.
Yeah, it's because with the different types of iron formulations, we have iron formulations that got really high levels of iron that your gut has to absorb, and some that have lower. And some of them, iron generally irritates the lining of the gut. So when you do take it, and if you do have a side effect, we just try and change the formulation so that your gut is happier with it. I typically ask my patients, like, you know, just take it in the evenings with, you know, with a
every other day. I think mine also
every other day is fine. You know, every other day is better than, you know, none. And now the guidance has changed. Before we used to load people up with like iron 2-3 times a day, but now it's just once a day. The evidence suggests that having it once a day is just as good as having it twice or 3 times a day. So that's, you know, that's perfectly reasonable. But it's a case of being just the perseverance and finding what works
for you as a person,
for you as well.
Oh my God, I'd love to have a full episode on gut health. You need to come back on, and we need to have another one on gut health, because gut health is so interesting to me. Honestly, it's actually madness. But I do think we're actually going a little bit crazy with our time. So I'm just going to ask you one last question, and this is, and I asked you this before, just, and I feel like you could mentally prepare for it if you wanted to, but it's, if you were sat at the top leaderboard, Prime Minister, top of the NHS, top of the system, what is it that you would change? I mean, I feel like you kind of said something before, like educational point, but what would you change then without getting yourself in trouble?
Well, I don't mind a bit of trouble if it make
everyone keep listening.
You know, if it'll make, you know, life better for not just myself but my patients and their families, because at the end of the day, the health is one thing that everyone would give anything that they owe to take care of. So I think at the moment, with the way things are, we're sort of just, there are a lot of good things happening, but you can't do good things without the right resources and right ways to make sure that they're sustainable. You know, the NHS is a beautiful system where it's supposed to be equitable and so on. But if you're not putting the right types of resources into it, then it just doesn't make sense. I think it's hard, but I know education is important, but I would say if we are looking at education, maybe for people who are looking to go into the field of, caring for, into the healthcare field, either as a clinical basis, non-clinical basis, maybe the education around prevention should be a lot more robust.
Yeah.
Also education on lifestyle prevention, So I've, as I said, I'm a lifestyle medicine physician. So it's not lifestyle medicine. It's actually not a clinical specialty recognized in the UK at the moment.
No,
in other
I
parts
don't
of
really
the world,
know many of them
it is a recognized specialty. So maybe that. So maybe changing that education system again from, for the healthcare. For the healthcare fields, focusing on
for example, GPs understanding that it's not always just
it's not about
medication, but it's actually what can they say to patients
So if they've grown up learning about the fact that everyone knows that it's good to be healthy, but how do I do that? Why do I need to? So on that understanding of the how and the why, and then and who it's relevant to, it's important. So that lifelong education, so in different spaces.
I love that. Amazing. Oh, well, thank you so much for being on my first solo podcast and your first ever podcast.
Thank you for making it so enjoyable. I didn't realize we'd actually gone through,
I know, I had so many questions. Jake was also like, please can we speak about this and this, touch upon that. But yeah, really missed you, Jake. And thank you so much again, Fatima. It was amazing.
Thanks for allowing me to be your first guest.
That's actually so fun. I love that. I'll leave everything about Fatima down below, and also where you can go and access her clinic and online practice, etc. But thanks so much, guys. We really hope that you took loads of information away from that. And hopefully we'll have Fatima on talk about gut health next time. But thank you very much. Make sure you like and subscribe, and we'll see you soon. Bye.
Bye, guys.
Yay. Well done.
That was so good.